If there are soft tissue restrictions between those muscle tissues, the subscapularis and serratus anterior, or the serratus anterior to the thoracic wall, that is going to have implications as far as motion at the scapulothoracic joint and length tension relationships and the capability of this shoulder complex to move normally. Okay? You allow their arm to rest over your arm, protract, retract. It's assessing not only for how much motion, what it feels like, and any symptom reactivity. Downward rotation, I like this because I can get right on the lateral border in that inferior angle and combined, just do them both together. It's supposed to let me come this way. And now what I can assess for is things like upward rotation, combined upward rotation with protraction. The serratus anterior muscle, let's say you want them to really work that upward rotation, protraction component. I can be providing manual resistance here. Her arm might just tell her, reach over her head and really push your scapula into my hand when you do that. So we get into interventions a little bit, really kind of push for it. There you go, push here. There you go. Medial border of the scapula, and then try to ride the scapula over their fingers. Angle. I'd get my hand right on the inferior angle, and then I can get my hand to try to slide in underneath. Assessment, okay? It's going to be a combination of getting your hands around the joint and also with your fingers trying to palpate that joint line so you can feel how much that humeral head's actually moving, okay? So from this position here, I have my fingers posteriorly on the head of the humerus there as best as I can, and what I'm trying to assess for is the posterior glide. Again, with my fingers posteriorly, I can just go right into the anterior glide. Now I'm not pulling him straight up. I'm superior, slightly medial, trying to feel for how much will that. The last one's the inferior glide. That one's tough, okay? Because what you want to do is you want to be in this position, but I know I can't go straight down. I have to go down and slightly lateral. At the same time, try to maintain that open pack position when I start to perform the inferior glide assessment. Again, with these fingers back here, I can try to get on that joint line, position them into full depression there. I just got to make sure that I'm getting a true sense for exactly how much inferior glide in the glenoid is, the humerus on the glenoid is actually giving me. Put your hips over there.
Oh.
Yeah, keep going. Now where's his aim? Now where is it? I didn't take my hand off him. Which way is his glenoid facing now? It's facing the same way, but in relation to the table and my body orientation, it's facing straight down, right? And I can be comfortable pushing more straight down the table. Again, my elbow's kind of getting in there. Again, I don't want to be here because if my direction force is that way, you always want that forearm in that line of force. So I'm on the spine of the scapula and the anterior acromion here. More so on the anterior acromion, just trying to prevent it from coming forward as I pull her clavicle forward, okay? But again, feeling with this finger right on the joint how much motion she gets. Anterior and posterior glides, okay? So when I do the inferior glide assessment, I am assessing for shoulder or clavicular elevation, right? The ability of the clavicle to elevate. Because as it's elevating, it's convex, so it's rolling superiorly. It means I need to glide it inferiorly. So we're doing the inferior glide. Once again, our SC joints don't run straight in line with the sagittal plane, okay? We're at an angle, an outward angle. That's how that maneuver, think of the shape of the manubrium, okay? Palpating finger is going to be the one that comes over the top, okay? Try not to get on your patient's throat if you can help it. That's generally uncomfortable. Find that SC joint line. You might even have the person shrug their shoulder up and down just to make sure I'm really on it. Then just have them relax. And then for the assessment itself, you need to get on the superior part of the clavicle and push inferior and lateral. This part is a E for people. Anterior clavicle, and I am going to push the clavicle posteriorly, feeling with this finger how much is the clavicle moving when I do that. Okay? And this is for retraction, clavicular retraction. How is that going to look on a person? Where should that wedge be? This wedge should be along the spine of the scapula. All right? You want to be on that. And you start looking for where that joint line is and how far in does that look like, okay? In particular, anterior. If you're going to do the anterior glide, just flip your skeletal model over. And then make sure that your wedge is situated so that the person can be on it, you know? So I have the person laying a little bit crooked, but if they weren't crooked, if I want to keep them straight, then that's what your wedge should look like. Notice that the wedge kind of points superiorly because the glenoid itself faces superiorly. And when I lay this down right on top of it, I see, oh, that's the straight line right there with the glenoid. It's right in line. They're in parallel with each other. So that it's right in line with the joint plane. The joint plane is the glenoid, right? Again, I want to double check where I am in relation to where I think that joint line is. The posterior glide. Because I'm going to be pushing the humerus posterior and slightly lateral. It's going to be my direction of force. And I don't want the scapula to go with me when I do that. Posterior glide is for what motions? Flexion and internal rotation, okay? So, I mean, if it's for internal rotation, I can take the humerus and try to internally rotate that some to get that towards that end range. We don't typically do posterior glides. Let's say they were limited in just those last 10, 15 degrees of shoulder flexion. We typically don't want to push through this way. Position. The more and more I get over his head, the closer and closer I'm getting to that closed pack position, and you don't want to be in that closed pack position. So generally speaking, at the shoulder, it is okay to not bring their arm all the way over their head when you're doing that technique. Just relax your shoulder as best you can. I just want to get a feel. So what I'm trying to do with my right hand is get a feel for, is that humerus posteriorly gliding appropriately? Am I at the right angle? Note, though, when we do joint mobility testing, okay, the scapula is sitting like this, and then I go slightly lateral. When I put a wedge under his scapula, what does his scapula do? What is his whole? I've protracted him. So you might note that the angle that you have to go lateral accentuates itself when the wedge is underneath there, okay? I know I need to go posterior and lateral, but just how lateral? How lateral do I go before I feel like it's moving the most? My line of force is going to be anterior, slightly medial. But again, if I've retracted him a bit, it might actually even be more straight down than you think. Again, extension is not in that close to that closed pack position. So if I wanted to see, well, there's his end range extension, I'm going to back off some. I think this is a good place that you could get away with that. And then again, just making sure you're only on the humerus going forward. Don't get on the acromion. Just be on that humeral head. It's going to be a distraction of the glenohumeral joint. So what does that mean? By definition, what is a distraction?
Perpendicular to the joint.
A movement 90 degrees to the joint's plane. So I am going to be pulling his humeral head in a superior, anterior, lateral direction. All three motions, because that's the way the glenoid faces. Where people make a mistake, hint, hint, don't do this on your practical exam, is they'll wrap the belt around the person and then they'll wrap it around the table. And when they do that, I'm going to clip them in, and I'm going to try to take up as much of that slack as I can in the belt. Okay? Just do me a favor, scoot just a smidge towards me, just so it should snug up a little bit more. I don't have to make it super, super tight. If I get it to where it's, you know, it's relatively snug, I can ask the patient to move into the belt, and that'll take up the rest of the slack. I got to move the humeral head, superior, anterior, and lateral. So what I'm doing with my arm is I'm getting my hand as close and onto the humeral head as possible. I am going to have him relax his arm because it's a passive technique up against my side. And then what I do, what I always like to do, just help me, I always interlock my fingers from underneath. You can lay one hand over the other, whatever works for you. But now my feet, if I know I'm going superior lateral, I want my feet in that direction for him. So then what I'm doing is I'm just locked in with my arms, and I'm weight shifting my body in that direction. And if I'm going to do a distraction, I have to find the end and then go into plastic range of deformation and hold. I'm not trying to make the movement happen with my arms or my trunk. I'm trying to weight shift my whole body. My upper body, my arms, my trunk, everything's locked in, and I'm just trying to weight shift my body away. Okay? To be looking at an inferior glide of the scapula. Okay? What I'm trying to avoid is how much of this depression happens, if possible. Okay? So again, I'm going to try to have them lock in, but do me a favor, bend your knees for me, and then scoot yourself down the table just some. Yeah, keep going, just until you feel like you can't go anymore. Like on the humeral head. And so remember, if he's straight, I got to go slightly lateral. Is going to be my direction of force. So my elbow's kind of slightly lateral, and I'm just pushing that direction with my arm. Remember, if I have him lay his hips further on the table, then I can do straight down. That had the little hole for the head. I could let this part of the belt go through that. Then I would put that piece back on top so they could rest their head there if need be. And that helped me get around the table easier. And that always worked very well for me.
Hypothenar eminence on your ASIS, so she's got to be off the edge of the table. If you hook it on here, you can keep your wrist nice and neutral, hook it on your ASIS, and then you're actually pushing with your pelvis, not with your arm. You're not trying to keep
to stabilize the the acromion, palpating finger, and because all I'm the only question I'm asking is how far it moves. I don't have to worry about, the fact that I'm pulling, not pushing isn't such a detriment because I'm not really trying to get much force. But now I am, right? So now I can get in the front and do the anterior glide by pushing, okay? Stabilize the acromion and just go through the mobilization. Find the end range, find that stop, and then go into Kaltenborn grade 3 and hold. In prone, you might even get the coracoid process to engage the table, and then you don't even have to worry so much about the scapula. You could just push straight down that way. I don't think I ever really did that. That's the AC joint, the SC joint. We have the inferior glide, the anterior and posterior glide. For the inferior glide technique, again, the ideal would be some pillows here so he can rest his arms in neutral position. All right? I find the joint line. It's more of a dummy thumb technique now, where I'm going to push through my right thumb with the force of my left thumb.
Your line of push has to be parallel to the line of the chest. So like with him, your line of pull, your arm's got to be pretty low to come here. Someone else whose chest is up here, you got to be even lower. So you just kind of pay attention.
For the posterior glide, excuse me, and then you're going to posteriorly glide the clavicle on the manubrium. Okay. For the anterior glide, we're going to depress the manubrium on the clavicle. Just use my thenar eminence on the SC joint. Okay. The other techniques, and we didn't do it as an assessment, there are distraction techniques that you can do, which can be pretty beneficial, and we can always show that. There's two ways to do it. The way I'm going to show you first is not my preferred way, but what you can do is, the idea is, remember the S curve of the clavicle, so it's concave at this end. The idea is you want with your hypothenar eminence to get that part, get in the hook of the clavicle there, for lack of a better term. I don't think it's called the hook of the clavicle, but then I can be here, or if I want to, stabilize the manubrium with this hand. And then what I'm doing, my mobilization is with my right hand, I'm just trying to separate the two surfaces. So now what my right hand's doing is this. The other way, and probably the more effective way, is lay on your side facing that way. Engage that hook again. Okay, two hands. 1, 2. Kind of a mini squat position, and what I can do is I can just lift and use his body weight. His body weight's actually the force of the technique. Get him up, moving around. Get that click that you're looking for, and their shoulders way out here, and it's achy and sore whenever they lift their arm over their head, but it's their SC joint that's the problem. Okay, that sternoclavicular disc, it's just not allowing normal movement, so then it gets stuck. And then that abnormal AC movement out here and extra forces that you feel it out here. And then you get the pop or the click, and all of a sudden it's like, oh, I can do that again.